Good afternoon, everyone. Welcome to Cardio webinar, Remote Monitoring for Diabetes, Embracing Technology to Improve Patient Care. I'm Dr. Michael Constant, and I'm pleased to serve as a principal investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio, at Case Western Reserve University School of Medicine. With me today is Dr. Sherry Boland, co-principal investigator of Cardio at Case Western Reserve University. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about our collaborative and to access our online repository of best practices, please visit our website, cardio.org. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the Cardio Collaborative a success. And with that, I'll turn the program over to Dr. Boland.
Thanks, Dr. Constant. So just some brief logistics. If you're joining as a group, please use the Q&A feature to record your names and emails of all the attendees in your group. We also have CME. To receive CME, you do need to register. So if you haven't registered, just make sure to use the QR code here, or you can use the link in the chat to register so that we can get the survey to you afterward for CME credit. And that survey will come from Kathy Sullivan, and it will be, you'll have about till Friday, June 24th to complete it. The other thing to mention here is just disclosures, and that Kathleen Dungan has reported a financial relationship with commercial interests, but we have mitigated that and made sure we only have relevant content for this particular webinar. Next slide. Just a reminder, our objectives today really define remote monitoring and technological options for diabetes management, to identify patient populations for whom remote monitoring is appropriate, and set up systems of care using remote monitoring for the intensification of diabetes management. And this is our agenda for the webinar. We're delighted to have our 2 speakers with us today to talk about ways we can implement remote monitoring in primary care. And I will introduce first Amy Zack, who is a family medicine physician at Cleveland Clinic and vice chair of education there as well as faculty at the Case Western Reserve University School of Medicine. She serves as the head of education dissemination for Cardio and will be moderating our webinar today and helping us get started and introduce the speakers. So thanks, Amy.
Thanks, Sherry. Good afternoon, everybody. Welcome. It's my pleasure to introduce our first speaker today, Dr. Kathleen Dungan. Dr. Dungan is a professor of medicine at Ohio State University in the Division of Endocrinology, Diabetes, and Metabolism. She serves as the Division Associate Director of Clinical Services, as well as the Director of Endocrine Clinical Trials, and oversees the inpatient diabetes program. Her research focuses on diabetes clinical trials and ranges from quality improvement to pharmaceutical and device interventions. So we are pleased to have her here to speak with us today and looking forward to her talk. Thanks, Kathleen.
Thank you, Amy, and thank you to the organizers to allow me to present to you today. I wanted to just start off with just some basic terminology so we can be on the same page. And as defined by Medicare and for billing purposes, remote physiologic monitoring has some very specific criteria. It's the collection and analysis of physiologic data, and that could range anywhere from weight to blood pressure to glucose monitoring, anything that's done remotely while in the home and is collected digitally. And we'll go over this throughout the rest of the presentation. And the appropriate candidates would be, from the perspective of glucose monitoring, is those individuals who are not at their target glucose values or A1C values, and who have access to a glucose monitoring device that can transmit digital data in some way. So that might be a device compatible smartphone. It might be that they have a computer that they can download their device. And so because this is digital transmission of data, we always want to be cognizant of the need to assess e-health literacy and be sure that our patients have the appropriate training. In terms of coverage, many payers, in fact, most payers do reimburse for these types of procedures. And in particular for Medicaid, there are a couple of blood glucose monitors that do have Bluetooth connectivity with an app that can be placed on the patient's phone. And then 2 continuous glucose monitors are covered and can be downloaded. And we'll go over some of those methods as well. In terms of the evidence base for physiologic monitoring, what I would draw your attention to is some of the studies that have been done with the telehealth approach. And this is an example of a systematic review that was recently published of 17 studies. And there are a number of different ways that telehealth can be delivered, as you might imagine. And so these various studies have demonstrated improvements in all sorts of physiologic parameters, but including hemoglobin A1C. And in particular, those studies which implemented automatic mobile transmission, or at least automatic transmission of data, or real-time feedback, provided the best A1C reductions, and you'll see that on this table here. And so that provides the framework and the rationale for remote monitoring in general. So how can we actually implement this on an individual patient basis? So back in the olden days, we used to use, I think, a lot more frequently, and we still do to some extent, the old paper logs. A patient could fax them in or even upload them to a portal of sorts. And that won't meet the criteria for remote physiologic monitoring codes. So, but there are several other strategies, and this might range from the patient downloading their device from home to a clinic account, or they might have a cellular connection to a clinic account. And really the most optimal strategy is yet to be widely available, but that is to have an interface where you have a cellular connection that links through various intermediary platforms directly to the EMR. I think we will see that happen in the future as this technology becomes more widespread and the need to actually support it expands. So a team role is very important, and it can't be done by a single individual. And there's actually some really helpful guidance in these references that I've provided for you here. The first is in diabetes education, and really provides the framework through which a diabetes educator might be used to, to serve as the champion of this program. But many other programs, as you'll see today, are led or at least run from day to day by the clinical pharmacist, and the other trained staff can also be utilized. And from the perspective of each step in that responsibility pathway, I would say that setup and training is critical. And importantly, I would emphasize that ongoing training and maintenance is needed. You can't just do a one-time set a patient up. And because there are so many things that can happen to a patient's connections and their understanding of how to use the technology. So ongoing for that first step, assessing what kind of readiness the patient might have, what kind of support they might need, and also documenting how they are linked to the clinic or how they are linked to their data is really important. You can have the same staff doing device downloads, but it doesn't have to be. In fact, in our clinic, we have just medical assistants that have been trained to do this. And you can start off with maybe 1 or 2 different devices so that your group becomes comfortable with it, and then expand as able. And then the data interpretation step really varies, and it varies based upon the codes that you're going to use. And then finally, who communicates the plan or communicates with the patient may also vary depending on which codes you use. So it doesn't necessarily have to be the physician or APP. So let's move on to a little bit more details and how to describe the different ways in which we can get data. I would start again with a Bluetooth enabled device. That data then is transmitted, importantly, to an app that the patient will have to put on their phone. And then that app then can be used to generate a report, such as a PDF, where they can create screenshots, which then they can either manually upload to their portal, or the clinic staff can take the data from the clinic account and upload it manually to the EMR. And then finally, these are being developed still, but some meters will connect with different types of intermediaries. In this case, this is supposed to be the Apple Health Kit, but also Redox is another platform that can, at least theoretically, in many cases, be used to actually upload data continuously. So first, I wanted to elaborate a bit more on these device-specific platforms. So these do require a separate account and maintenance, and sometimes there's a need for periodic updating of passwords. But basically, in the 2 CGMs that are Medicaid, that are approved widely for Medicaid and the Medicaid managed care plans are shown here, and the 2 softwares that are used for the Freestyle Libre, you can take an app with or use the receiver and download that through the computer, or as I said, through the app, and then the patient will enter a clinic-specific code to permanently link through their app, or you can send them an invitation email. And then for the Dexcom, a similar process, either using the app or their computer with a specific receiver. And in this case, the clinic generates the code and can send by email or print, or a patient could also generate a share code and share with the clinic. So in terms of the actual what the patient sees on their end, there are some pretty easy steps for the Freestyle Libre. One thing that is important for them to understand is that when they start a new sensor, they should start the app. If they want to use both the app and the reader, they need to set up, connect with their app first. Or I'm sorry, backwards. They must connect with their reader first, and then they can use both. And then this is what the steps will look like. It's pretty straightforward. Click on the menu, click on connected apps, then connect to the appropriate app, connect to practice, and then enter in the clinic specific ID. And then this is what the clinician will see with some of the patient specific information blanked out here. You can do a specific search, but on this platform, the LibreView platform, you can actually sort patients and be able to customize the columns to show what you want to use if you were going to have more of a population health approach and see which patients are in need of attention earlier rather than later. And then you can also see how and if they are connected to the clinic, and if they're not connected, you can send an email invitation. For the Dexcom, similar process. Click on the profile in the app, put in the clinic or the clinic generated code. And this is a patient specific code, so it's a little bit different. And then as easy as clicking the share And then from the clinician side, if the patient is directly linked to your clinic, this is why it's good to always know, so you're not going through multiple different hoops to find the data. You just go ahead and log in and search for your patient by name. And if not, if they're using their own share code, you can enter it in at the bottom right-hand corner. A few troubleshooting pearls. If you can, have the patient check their compatibility of using their phone prior to choosing a device. It's possible one phone might be compatible with one device and not the other, and that might preclude the use of the app. And if they can use the app, to set that up, and that's why the training piece is so important. And if you're in the midst of doing some virtual type of visit, you can check where the patient's linked, and if not, having the staff automatically send them an invitation or get them linked, so that way you are not having, as a clinician, having to do that. For the Dexcom, again, I would just strongly recommend doing direct links, because if you're having to create new share codes, that eats up some time and can be challenging if patients have to reactivate their passwords. And one other thing is, there are several different apps out there, and so the patients will have to use more than one type of app to make their Dexcom functional. So it's the Clarity app that's actually sharing their data, not the Dexcom app. And then finally, the Libre, the two important points that the patients should be scanning regularly. The memory is only 8 hours, so if they're not scanning frequently enough, you can lose data. And then thinking about using the Freestyle Libre 2, because that provides actual audible alerts if the glucose thresholds surpassed in the high or low range. And even thinking bigger picture, this is not available yet, but we would, from a population health perspective, you might think about having a type of prioritization plan. This is an example of a homegrown strategy that balances out the percent of time that a patient is in hypoglycemia with hyperglycemia, and then prioritizes the patients according to their algorithm. But on a lower tech type of approach, you might want to just use the following type of strategy. So first, look at hypoglycemia. Is the time that they're spending in hypoglycemia or time below range exceeding their individualized target, which is more than 4% or more than 1%? That's individualized based on a number of risk factors. Address that first, and then if their time in range or time in target between 70 and 180 is below the threshold, then you can address whatever patterns that you're seeing. So typically the time in range target is less than 70, is more than 70%. So if they're below 70%, then you want to really think about making some modifications. If someone has a higher A1C target, then a threshold of closer to 50% might be more appropriate. So this resource will be provided in the links at the end of the presentation, and will also be available on the Cardi-OH website. But it gives you a sense of the landscape of the types of remote monitoring codes that can be used for this purpose. So the 99453 through 99458, these first 4 codes, the really nice thing about them is they can be used under general supervision, which means that it doesn't necessarily have to be done by a physician or APP. And keeping in mind that these codes in general require some type of a consent, and they can be used all 3 together when appropriate, or whenever it's appropriate. And if you're exceeding more than 20 minutes in a given month, then you can use an add-on code. Now, the interpretation of blood glucose monitors or insulin pumps can also be billed using the 99091 code, but that needs to be a physician or other qualified health professional. And that requires 30 minutes minimum. And if you're using if you're interpreting CGM, in general, it's preferred that you use the CGM specific codes. The only thing is that these cannot be billed, these have to be billed by an APP or a physician. Now, the advantage of using the CGM codes is if you're also doing remote monitoring for blood pressure or another parameter, you can use both of those. Whereas if you're just using remote monitoring for glucose, you cannot use it for blood pressure as well. You know, you can choose one or the other. A little bit more detail on the CMS rules. Again, devices must be digitally reporting the data. It can't be manually recorded or reported. And it needs to occur in general, at least 16 days out of a 30-day period. Now, during the pandemic, there is some exception to that rule to 2 days. And again, only one provider can bill at a time for this on a monthly basis. And these are some of the other public health emergency modifications. Some of them will change. Setting an A1C goal is something that we're pretty used to doing, I think. And so this is just another way of looking at how to maybe set those targets for time and range. So if your A1C is 7%, that time and target range should ideally be more than 70%. Whereas if it's 8%, then 50% time and range would be a reasonable goal with the commensurate hypoglycemia parameters. And let's put this finally into practice. This is an example of an ambulatory glucose profile, which is a standard report. And you can see over here on the right, first of all, the time that the CGM is active is 95%. And really for sufficient data to be able to predict A1C and have a reliable assurance that it's sufficient, you want to have at least 70% of the time recorded. You've got your average glucose over here, and the coefficient of variation is helpful because it gives us a sense for what the risk for hypoglycemia is. And then we've got the time in range here is 45%, so that's low at any standard. The time below range, 0.6%. And then looking at the actual graph here, this is representative of where the patient is spending the majority of their time, with your average in orange, the 75th percentile in blue, and 90th percentiles in that green dotted line. And then you can see that this patient is maybe highest here in the afternoons. Perhaps there is a lunchtime issue. Glucose is a little bit high overnight as well. And just a couple of examples to finish up here. This is a patient who has type 2 diabetes and no complications. When we look at this AGP, we've got a good amount of data, more than 70% of the last 14 days. The estimated A1C is 8.5%. And the time and target range is pretty low. And looking at this, it's pretty easy to see that the glucose levels are climbing throughout the day as the patient is eating. And that wouldn't be too surprising looking at their regimen here. They're on some basal insulin, they're on a GLP-1, metformin, and a glimepiride. And so in talking with this patient, the initial reflex might be to just keep going up on the basal insulin because your fastings aren't quite quite where they need to be yet. However, I would argue that given that the glucose level here is so high and drops about 100 points overnight, that you'll actually get more benefit from just adding a dose of insulin at supper here. And so that's what we did. We also titrated the dual glutide a bit, and I think once you're starting prandial insulin, you can probably try to get them off of their sulfonylurea. And then the final case is a little bit different. Now it's already someone who's already on mealtime insulin, which might be more common for our CGM patients. This is a patient who has chronic pancreatitis and has a low C-peptide, so functionally more functioning as type 1 diabetes, but also has some complications here, heart failure, and has a lot of limitations with their lifestyle as well in terms of frequent travel. And so a lower target might be more appropriate for this patient. So looking at overall, how much data do we have? About 90% of the time is great. The A1C is reasonable for the level of comorbidities for sure. But when I'm looking at the time and range here, this is probably a bit more hypoglycemia than I'm comfortable with for this patient. And if we look at the trends here, we can see that there is this very consistent spike after lunch and then hypoglycemia later in the day. And this is a patient who's on basal bolus insulin. So this is going to open up some more questions. This is the overlay reports where we can see some spikes more clearly post-meal at lunchtime. And it turns out this patient is just not on enough lunchtime insulin, so we can increase that. But then the patient's also performing repeated corrections post-meal and dosing their insulin post-meal. So we can fix that. And that is really what's causing these hypoglycemic events, that we just need to retime their doses of insulin and not do post-meal corrections. And we can also get them into education. That should not be underestimated. All right, so I'll finish up here. There's some resources that may be helpful to you, both from the Cardio website as well as from the manufacturer, and there will be additional resources at the end. And I thank you for your attention.
Thank you so much, Kathleen. And now I would like to introduce our second speaker today, Megan Rasch. Megan is an ambulatory clinical pharmacist at 5 Rivers Health Centers. She works closely with family and internal medicine groups in diabetes management. 5 Rivers is heavily focused on interprofessional diabetes management, working with continuous glucose monitors for about a year, with a greater focus on remote monitoring in the last 6 months for improved glucose control. Megan is going to share with us today their experience with the implementation of the use of continuous glucose monitoring in their patient population. So thank you so much for being here.
Thank you so much for having me, and thank you all for attending today. So yeah, our goal is to really walk through how we've implemented this across our health centers. For those of you that don't know 5 Rivers, we are a federally qualified health center located in Dayton, Ohio. We have a number of different primary care services, specialty care, and then we also have 2 retail pharmacies, with one also serving as a specialty pharmacy. When we first thought about CGM integration, we mostly talked about our main primary care sites, which are the 4 that are listed on the screen. So one of our large sites is our internal medicine location, where we have 1 clinical pharmacist and a pharmacy resident. We have 4 private providers, and then this is the location for the outpatient experience for the Wright State University Internal Medicine Resident Group. We also have our family medicine location, where we have 2 clinical pharmacists, 3 private providers, and this is the location of the Wright State University Family Medicine Resident Group. We also have a clinical pharmacist a half day every week at our Samaritan Health Homeless Clinic location to help serve our 1 nurse practitioner there. And then we have a clinical pharmacist a half day every other week at our Greene County location, serving the 1 nurse practitioner we have out in that location. The role of our clinical pharmacists within our clinic is mostly referral based, so obviously we answer lots of questions throughout the day as well. We have a number of different collaborative practice agreements where we work under our providers, but one of them is diabetes focused. And so the referrals we tend to receive for patients for diabetes tend to be newly diagnosed patients, patients with A1Cs greater than 9, And most of them do have type 2 diabetes, but sometimes we see a type 1 every here and there if they're trying to get connected with an endocrinologist, just kind of in the bridge time. During these visits, we do evaluate and discuss the possibility of a continuous glucose monitor. And then once our patient achieves their A1C target and their health maintenance items are up to date, that's when we send them back to their primary care provider and they're disenrolled from our program. The way when we see patients within our pharmacy visits, there's two different types of visits the patients might be able to see one of our clinical pharmacists. The first one is a pharmacy only visit where the pharmacist rooms the patients, gets their vitals, gets their med history, we perform the whole visit, we order whatever medications, labs are appropriate, and then we also schedule a follow-up visit with them. But for our diabetes patients, not only could the patient be seen in a pharmacy only visit, they could also be put within our diabetes bridge program. This program is only at our internal medicine location at this time. And it started about 6 months ago, but it is a team approach. So we have a nurse that rooms our patients and she'll obtain their current blood sugars, discuss their current exercise habits. And then we have a dietitian on this team as well that will talk to the patient, obtain a meal recall, and provide lots of education for the patients on their diet. And then the pharmacist will go in to provide more further education, order meds, labs as appropriate. And then we also have a community health worker on this team. And that individual completes reminder calls for the patient, makes sure that they have transportation, and truly is the patient advocate. If a continuous glucose monitor is ordered by one of our pharmacists, this is kind of the process that we go through. So during that initial visit, if we're considering a CGM, we'll discuss with the patient the pros and cons of that CGM. We'll also evaluate that patient's phone for possible compatibility. We'll submit a PA if it's needed, depending on the patient's insurance, and ultimately send the prescription to one of our retail pharmacies. If the patient can fill with our pharmacy, or if they're interested in filling with our pharmacy, we can get that ready for them and make sure that there's no issues with that prescription. But if their insurance does require them to go somewhere else, maybe it's covered through their DME supplier, what have you, we will still follow that through to make sure the patient actually gets that CGM. Once the patient actually receives it, we will schedule a placement or education appointment, and then we'll remind that patient to make sure they have the app downloaded before their education appointment, if possible. Then when we actually see them in the office, we do a full education visit. So we'll make sure again that that app is downloaded if they're planning on using it. We'll educate them on the different supplies and show them how to actually place their sensor. We do use the teach back method to make sure the patient does feel comfortable placing the sensor on their own. But for some of our patients, they prefer us to place the first one just so that they kind of know how it feels. And then they'll come back and place the next sensor with us watching. During that visit, we do try to get the provider clinic code up and running and make sure that that link does work. So we'll either send them the email invitation or provide them the code for either the LibreView or the Dexcom Clarity. And then the last thing we do is just make sure they have an appropriate upcoming appointment with our pharmacy team. Ideally, these patients are seen back within that bridge program. And what's really nice is our nurse is able to download either the meter or able to find the patient on one of the portals. And then she'll print off that CGM report and make sure everything is ready to go. So everything's consistent within the clinic. And then once that report is printed off, it's handed to the dietitian. Our dietitian has really loved seeing these CGM reports because it helps them educate that patient with a little bit more focus. So if you do have a meal that they're spiking after, she can kind of talk to them about how many carbohydrates might be in that meal and really help further that education. And then from our perspective, as you've seen, it's very helpful to have a CGM report to educate the patient. And then we also help with a lot of the troubleshooting and making sure everything's working appropriately and part of that educational process. And then as far as our documentation, I thought it might be helpful for you guys to see this. This is the dot phrase we put in all of our notes just to try to make it as consistent as possible. So we put in their average glucose and then we put in the different percentages we tend to look for. And then we talk about any potential trends and kind of explain why we're changing what we're changing. The other nice thing about having this documentation be consistent from note to note to note is that the patients really like to see either their average glucose go down or that percentage within range go up over time. So rather than having to wait the full 3 months to see, how am I really doing for that A1C check, saying, hey, 3 weeks ago, your average glucose was at 250 and today you're at 230, it really helps to motivate that patient. So I do like to share those things with our patients just to keep them motivated and engaged. So if, on the other hand, the CGM is ordered by one of our other providers, so not within a pharmacy visit, usually our providers will send us a message. But if not, if it goes to our pharmacy and it requires a prior authorization, it usually gets printed and handed to the clinical pharmacist that works the closest with that provider. And then we'll document that it requires a PA and all of that into our EMR. And then we kind of go through the same process. We'll submit the prior authorization. We'll make sure that the patient actually gets it, whether it's through our pharmacy or somewhere else. And then if it is picked up from our pharmacy, our retail pharmacist will ask if they need help with setup. And if they do, they'll send the clinical pharmacist a message and see if they have time to do a complete education. And if not, then they'll schedule just an education visit with the patient. During that education visit, basically we go through everything we would have done for that patient if they were following with the actual pharmacist. But at the end, we just make sure that they do have an upcoming visit with either the pharmacist or their provider. The other thing we have to look out for is if a patient is started on a CGM from a provider that's not used to working with them or hasn't worked with them before, we'll look at the Dexcom Clarity and the Libre View to make sure that that provider is on our care team. And if they are not, we know that they haven't been educated on how to actually get to those reports. And so we usually will try to find that provider within clinic and do like a quick 5 to 10 minute overview on the platform and make sure they feel comfortable with what they're looking at when that patient comes back in. And it kind of gives us an opportunity to kind of touch base about that patient and make sure that they feel comfortable with everything. And then from there, the other thing we'll do is we'll make sure that that CGM is on the medication list. And we will actually just add a comment on the med list saying if the patient's virtually enrolled or not. So that way, when the patient comes in, we know where to look for that information, if we should be expecting them to bring in their reader, or if we should be looking online to make sure that we can see their most recent blood sugars. The other thing that we've been doing and we've been slowly kind of integrating is at each location, we try to have a nurse or an MA that at least knows how to obtain the CGM report, or at least how to connect with the clinical pharmacist for questions to make sure that if a patient does bring in their meter or says, no, everything's on my phone, they're able to quickly get those blood sugars so that the provider seeing the patient that day can evaluate those appropriately. And then lastly, just if there's other troubleshooting needs, we would just want to make sure the patient, they're all aware that they are welcome to schedule the patient for a pharmacy visit anytime. So if their sensors are falling off, if they're having a lot of issues, we usually just tell the staff, then we are happy to see them, feel free to just schedule them and we'll kind of walk through any of the issues that are going on. I wanted to review a couple pearls as we were going through this process, some of the things we learned. So the first thing is there are specific drives that need to be downloaded on whatever computer you're going to use to be able to view the report. For us, this required admin login, and so our IT team did have to come and log in. So we only put it on certain computers. So we have it on all of our clinical pharmacist computers, and then we also have it on commonly shared workspaces. So whether that's a computer space on wheels or just a computer that's usually available within the different clinic sites. And then at least within our population, we are really excited to do remote monitoring, and we're really hopeful that all of the apps would work beautifully. But within our population, not everyone has a compatible phone, or they change phones frequently. And so it makes it more challenging to be able to get everything to come across appropriately for as long as we want it to. So we do have a number of patients that we still manually download their data from their receiver, from their CGM. So it's just something to keep in mind. And then I think it's important to designate at least 1 or 2 people at each location to understand how to download these reports, just because it can be a little tricky and you just need to know exactly where to go for that information. And you want at least 1 or 2 people, at each location to make sure they can at least find the reports. And then lastly, designating someone to be able to help educate patients on how the CGM works and doing that initial education piece is an important step, and not one that I think we should forget about, because we can't just hand the patient a CGM and expect them to know everything about it and be able to place the sensors and do all of that. So I think it's helpful to have someone actually sit down and educate these patients, and you want to make sure that person does tend to have openings on their schedule. You don't want a patient to have a CGM and then have to wait 3 months before they're able to place it. So I think it's helpful to have, a couple openings throughout the week at least that are dedicated to some of these educations. So transitioning to what's coming next, I think a lot of our education right now, as I mentioned, is primarily our clinical pharmacists. But I think that this is a potential opportunity for some of our nurses to get involved as well. Now that people are starting to feel a little bit more comfortable at our sites, I think it would be helpful to, have more people available to be able to do some of these educations. So our thought was to start with the nurse that's primarily in our bridge program, because she's seen us place a number of them. She's seen us educate a number of patients, and she's used to downloading the reports and knowing how to send the links and all of that stuff. And then I think ideally it would be amazing if all of our MAs and nurses know how to find and download those CGM reports. But I think specifically within our resident clinics, just because those providers do change over frequently and we are educating them, frequently, just because their schedule is crazy, that it would be helpful to kind of focus on those particular people. And then lastly, just continual education for all of our staff. Before I leave you guys, I did want to share a little bit of data. So these are patients that filled a CGM just at one of our 2 pharmacy locations from April of 2021 to April of 2022. So before the patients obtained their CGM, their average baseline A1C was 11.5%. Their most recent A1C was 8.43. So that's an average A1C change of about 3%. So this is really promising data for us. And so I think we're going to continue utilizing CGMs to the best of our abilities.
Thank you so much, Megan. We appreciate both Megan and Dr. Dungan for being here today. At this time, I would like to invite anybody who has a question to please ask through the Q&A function on Zoom. We do have a few questions to get started with. Does a clinical pharmacist count as a qualified healthcare professional? How about an NP or a PA?
That's a great question, and it depends on your coding, which ones you can use. So the 99453 through 8, those in fact can be built by the nurse, under the general supervision of a physician or APP. For the 95251, that CGM specific code, that's supposed to be billed by a physician or APP. And that doesn't mean, however, that that other staff aren't involved in obtaining the data and even communicating the data. That code can be used with a 25 modifier in conjunction with an in-person visit, a telehealth visit. So it is a code that can be used in a lot of different formats, but it doesn't necessarily have to be. It can be in just outside of an office visit per se.
Thank you. And for Megan, where is the physician involvement in the care in the Diabetes Bridge program?
Yeah, great question. Thank you for that. So with our physicians, they are sent all of the notes from our Diabetes Bridge program at the end of the visit. And then our physicians still see these patients regularly. So it's not like they stop any type of their normal care. That's just kind of an in-between the provider's visits to be able to help out with these patients and give them a lot more diabetes-centered education. So for example, a provider might see a patient and then they notice their A1C is greater than 9, they'll send that referral and they may still want to see that patient back in a month. in which case we would still see that patient as soon as we can, and we would do our education piece. And then that provider would still see them kind of on their normal basis and how they'd like to see them. So it doesn't change from their normal workflow. This is just an additional benefit that the patient can come and meet with us as well.
And I think for both of you, who can provide initial training for the providers? The companies or other folks, it's this person said they've had a lot of trouble reaching the Dexcom and Libre reps.
Yeah, I mean, at OSU, this really evolved from the blood pressure monitoring, remote physiologic monitoring programs. So you can check throughout, your institutions or affiliations to see if there are others who are doing remote monitoring. Again, even if it's not glucose monitoring, you'll have a place to start. And then a lot of this does require some legwork and a champion to really try to dive into this and understand and create a process. So I encourage you to look at the references. We can put that at the end of the presentation as well and on the website. And then there are webinars that are recorded by the manufacturers, both Dexcom and Freestyle Libre, and also Medtronic for that matter. There are some webinars and resources on their websites that you can review. But when we implemented our programs, it was not done through the manufacturers per se.
Yeah, and I will just add to that as well. I think the biggest thing is having a champion. Luckily, before I had started, we have a wonderful clinical faculty member here at our location. And so she had connected and already had a lot of the drug reps numbers and all of that stuff. And so I think it's just important to have a champion. And then for us, because our clinical pharmacy group is so small and we're at so many different locations, we are able to, through our smaller group, then educate, a larger group of people.
Thank you. Can you discuss sensor placement and if there are any problems with adhesive, especially with elderly patients who cannot easily access the ideal site? Megan, do you want to?
Yeah, I can start. Yes, a lot of patient sensors, unfortunately, do sometimes fall off for whatever reason. I have one elderly individual. I also have one individual that works out in the sun all day, so he tends to sweat a lot and then it comes off. There are a number of applicator tapes that you can buy on Amazon or other locations that will actually go over the sensors and they stay on much better that way. And so we usually will try that after that. And I always tell my patients, yes, it happens, it can fall off and, your insurance may not let you get another one for whatever time frame, but we can always go back to you using your glucometer with your test strips, go back to the old fashioned way of making sure we're at least checking your blood sugars in some way. But usually the different tapes and things like that are really helpful to keep those sensors on.
Yeah, and then the other issue is that if it's not falling off, patients will also have difficulties with irritation and allergies, and sometimes it's bad enough to need to switch devices. It doesn't always cross over, but there are a number of different types of topical applications and barriers that can be helpful if the irritation and or itching is not severe. And then the other thing, as far as the placement for older individuals, sometimes they have difficulty kind of going to their arm. Technically, the Dexcom is FDA approved for use on the abdomen, but throughout the pandemic, we've used it in the hospital on the arms, and there's some reasonable data that it's accurate on the arms. And then the Libre is FDA approved for the abdomen. So you might think about that and the patient's ability to place the device.
There's a couple of questions here about the patients being able to afford these CGM devices. And is the reimbursement adequate to cover services provided? And specifically for those who are uninsured or perhaps underinsured, what is your experience and what would you recommend for help supporting the patient access?
Yeah, so obviously at an FQHC, we do see a number of patients that are uninsured or underinsured. We do have a wonderful team here that tries to get everyone insured if possible. And so we try to get most patients, insured if they can. And for some people that are underinsured, unfortunately, there is sometimes a copay. So it's having that risk versus benefit discussion with that individual. And so we usually kind of start there. And sometimes we just can't get access for every single patient, no matter what we do.
Yeah, it's a real struggle if you're not insured. There isn't a great way. I mean, there are samples that are available, but they're not intended for that purpose. So there really isn't. It's got to be more, and that's really a huge gap for uninsured or underinsured patients. Any kind of glucose monitoring supplies is very difficult.
There is a question about whether it would be the PCP that would be making use of CGM and remote monitoring devices, or whether you might refer to somebody else who does. I think you guys could probably speak about two different experiences there, and who is managing this care and what your experience might be with that.
Yeah, so from my perspective, working with a number of primary care providers, a lot of our providers do refer to our program to get patients just at least started on the CGM, just to do some of that initial education. But I don't think that's, just because we're here and we're available, it makes it easier on our providers. But I don't think that should be a reason to deter primary care providers from, obtaining these for their patients. And, having some champions to make sure you guys really do understand how to use them and make sure you feel comfortable reading the different reports. So I think it's something that a primary care provider would be able to do. And we've educated a number of them, and a lot of our patients, end up going back to their primary care providers. So it's not a continuous follow through for us.
Kathleen, could you speak to where you use the reports in your workflow in managing your diabetes patients?
So as Megan mentioned, I do like to share the reports with the patients when I'm in a face-to-face, whether it's video or in-person encounter. But if not, if I'm using a patient portals type of messaging function, it is nice to give them a snapshot of their report and provide it some description of what their control is like. So it really kind of depends, but usually in actual visits or in a structured program where you have remote monitoring and a regular cadence of accessing and the data and communicating, which could be through the clinical pharmacist, which is really how at OSU within primary care and more recently endocrinology, we've been using those reports.
For Megan, what is your process in determining criteria for the Libre or Dexcom?
Yeah, that's a good question. I would say that it is, I think I'm seeing the comment here related back to insurance. So our insurance companies do sometimes drive what their requirements are for someone to have a continuous glucose monitor. So I kind of have a general idea of what most of those are just because I have been doing it. But a lot of them do require the patient to be on a set amount of insulin before they would actually allow this. But I feel like now things have really changed and most of our patients are able to get them if they're interested. So we still do mention it to our patients, and especially if someone is complaining of not being able to poke themselves or they don't want to check their blood sugars frequently, we do bring it up as an option. So I feel like the requirements recently have changed quite a bit for insurance companies, and they've really opened up the field to allow us to get these continuous glucose monitors for a number of patients. But as you saw, the reasons for referrals for us tend to be newly diagnosed and patients with A1Cs greater than 9. And so we are seeing those patients, a lot of patients that are uncontrolled. The other population to consider using a CGM for patients that go hypoglycemic frequently, especially asymptomatic hypoglycemia. So I think those are the patients I tend to think about when I'm offering a potential CGM. We also have some Dexcom Pros in our clinic, which are really helpful just to give it a trial run to see if that patient is interested.
We have a few questions on the integration of this information with the EMR systems, specifically Epic, for example. Any tips for transferring information, or how do you interface that information into Epic or your EMR?
So for us, you guys saw the note template that I tend to use, and that's in all of our visits. And then we also just print it off, and then we upload it into the patient's media tab within the Epic system, or we'll transfer it electronically. We'll download it, and then we'll just put it right into Epic, just so we have that available, so we know what we looked at when we saw the patient at that visit. But it does store a lot of that information within the Dexcom Clarity portal and the LibreView portals, so you can look back and see that information. But I haven't seen any integration, at least within our computer system of Epic.
Yeah, it is coming, hopefully soon. At OSU, we're working on the integration capability. Freestyle Libre can integrate with the use of the intermediary called Redox. There are still a number of steps, in terms of connecting the patient to Libre and then through Redox to Epic. And there are ways that you can customize what those reports look like and how much detail actually goes into the glucose flow sheets. And then the other possibility that is technically available, but probably most institutions don't have it, is with those meters that with the Bluetooth connection that can connect to Apple Health Kit. There is some functionality available. It's not a default functionality and has to be customized for that data to stream into the glucose flow sheet function of Epic. For the other EMRs, I'm not exactly sure where they are with that.
So unfortunately, we do have a couple other questions. We will make sure we type some answers out to those questions we have not gotten to. I want to give a huge thank you to Kathleen Dungan and Megan Rasch for their time today, and to all of you for your attendance. I think this is where we're headed in the future, and it's so helpful to hear about real world experience as we try to get our head around it. And I think at this time, I will pass it over to Sherry to wrap us up.
Thanks. This has been a wonderful discussion and webinar, so thank you to everyone. Just a couple logistical next steps. I know a couple people mentioned wanting slides or resources. All of the resources mentioned in the webinar today will be on our website along with the slides, so you'll see all of those as well as a resource list. I also just wanted to comment, if people are not aware of this, that Medicaid did start covering both the diabetes prevention program this year, as well as last year started to cover the diabetes self-management education. And so if you had not heard that before, I just wanted to bring that to your attention. And there's more information about that on our website as well. Next slide. Just again, if you join late, CME reminder, you do need to register so that we can have your email to send you the CME survey. So you can use the QR code here to get to that if you didn't register, or it will be up in the chat as well for you to register so that you can get that CME survey. Next slide. And this is just a general survey for everyone. We do want to make these webinars as wonderful as we can. And so getting feedback is really important to us. You'll see the link to the survey. You can take it now or you can take it, we'll send an email out afterward to get your feedback. So you can also take it afterward at a different time. And we'd like those by, I think, June 3rd. And just again, any other additional resources are on our cardio.org website. We have podcasts. You can sign up for monthly newsletters. And we also have a wonderful team-based virtual learning model that you can see more about. And we have an upcoming series for that in the fall. So thank you, everyone, and excited to have this wonderful webinar today. And we'll see some of you hopefully soon. Take care. Have a wonderful afternoon.